आराम से चलो, आराम से भाई। 5 मिनट लेटे होगा तो कोई दिक्कत नहीं है। 5 मिनट लेट होगा कोई दिक्कत नहीं रहेगा तो। नहीं, पहले नहीं, वही मेरे पास में नहीं, वहाँ कर दीजिएगा। वहाँ तरह तो तरह हुआ है तो वही है। सब पूरा जाम हो गया।
Good evening, sir. Sir, good evening.
Good evening. You can start.
Good evening, sir.
Sir, you can start, sir.
So, very good evening. For the next 40-45 minutes, we are going to see about seizure spectrum. So, how you are going to approach seizures in presenting to the emergency room. As a part of emergency medicine, seizure is one of the very important condition which we regularly encounter in day-to-day practice. Before starting this session, I like to thank my mentor, my guide, Dr. N. Balamurugan, a neurologist. Without his help, I would have not been able to excel in the neurology. So, a seizure is defined by release of excessive and uncontrolled electrical activity in the brain. Seizures, as it is just
बेटा उठो।
seizure is not a disease, it is just a symptom. Okay, it is just an event. So, epilepsy is a disease. So, it is a neurological condition which is called a seizures disorder that in different time produces a brief disturbance in the electrical function of the brain. Seizures are the symptoms of the epilepsy. Epilepsy is the disease. Seizure is not a disease, it is a symptom. First, you have to able to understand this difference. How the seizures are classified? Many times in the emergency room, the patient will come to you and say that patient had only abnormal movement in the right upper limb, or there is a abnormal movement in the cheek, or the patient had all four limbs movement. Like that, they will describe. So you need to know whether it is a focal seizure or generalized seizure. So in focal seizure, what will happen is there is only one focus that is causing an abnormal discharge. Okay, so you can see this video how this focal seizures will be there. Just a lips matching. So this is a focal seizure. The cause for the focal seizure is, you can see a single contrast enhanced lesion. Okay, this is the lesion causing the seizure. Okay, focal partial seizure is there. Okay, so partial seizures are divided into simple partial, complex partial. Simple partial means here the conscious is not impaired. There is no issues for the conscious. Whereas in a complex partial, the patient will be unconscious or will be in altered sensorium. So about 2/3 of patients with epilepsy have a complex partial seizures. Okay, I'm just seeing a simple partial seizure. You can see there's a small. See, this is a simple focal partial seizure. Here the patient conscious is preserved. Whereas this is a complex partial. See, so here the patient conscious is totally, patient is not in conscious, and you can see this. So this is a complex partial seizure. So here the patient will have a aura, automism will be there, after effect, confusion, that is post-ictal state will be there. It can affect all the age group, and the duration will be 1 minute or more. If you do a EEG at the time, the video EEG will show you a sharp flowing waves on the EEG can be seen. So this will give a clue that the patient is having a complex partial seizure. So if you move on to the generalized seizure, here the focus will be generalized. So many focus will be there. So generalized seizure, again, it can be divided into two: convulsive seizure or a non-convulsive seizure. As a physician, we need to be very cautious in any comatose patient coming to the emergency room. or the patient admitted for some other reason and found unconscious in the ward or in the ICU, you have to think non-convulsive as one of the differential diagnoses. Then if you are moving into absent seizure, again we have two types, typical and otherwise atypical seizures. I'm just showing you this spectrum. So initially it started like a focal seizure and degenerated to a generalized tonic-clonic seizure. Okay. So this is also another case you can see. Actually, so patient is fully conscious. I'm provocating with the asking the patient for a hyperventilation. So hyperventilation, the patient is going for a seizure. So this is very short attack. Okay, this can be called as an absent seizure. So usually they will lag for 5 to 10 seconds. They will have a several attacks in the day. 50 to 100 attacks per day will be there. Sudden onset, sudden end of the attack will be there. And specifically we see in the age group of 4 to 8 years. Okay. If you see there will be no post-ictal confusion or any other thing, they will be very normal. See in this patient, actually she didn't know what has happened. Okay. It is not associated with any loss of body or tone, change in the tone or fall. If you do a EEG, you can see a generalized spike or a slow wave can be seen. So this is all about absence seizure. So kindly remember the tonic-clonic seizures, we called as grand mal seizure initially. Now it is called as GTCS, generalized tonic-clonic seizure. Often this is preceded always by an aura. Tonic phase, the muscle will be stiffen up and lose the consciousness, and then the body goes rigid in this. And the clonic phase, the patient will have a jerk and twitch or any abnormal movement will be there. So atonic seizures are there where there will be a sudden lack of muscle tone causing them to inability to sit or stand. Okay, it is otherwise also called as an akinetic seizures. Very rare in adult. They will have a fall. Okay. So now how we are going to approach. This is an approach, a stepwise approach by the emergency physician in the ED. Okay, it is not a classical neurological approach. Okay, so this is just in the ED approach. First, when the patient's attender says that the patient is wheeled in inside the ER, saying that patient had some kind of seizure. Okay, so first thing we need to ask, is it a seizure? Okay, then whether you need to ask whether it is a provoked, it is symptomatic, or it is unprovoked seizure. If it is unprovoked, we need to ask whether it is a single or recurrent attacks. Then what type of seizures is it? Or it is belonging to any epileptic syndrome. So we will see all these things one by one. Is it a seizure? So actually this is a case, patient brought to the emergency room. It's a 15-year-old boy. History of recurrent episode of LOC associated with abnormal involuntary movements of limbs since 2 years. Family history of epilepsy is there. Elder sibling is suffering from seizure. Okay. And diagnosed to be as a case of temporal lobe sclerosis, and patient is on anti-epileptic drugs. Just watch this video. Is it a seizure? Kindly interact. Is it a seizure? It is not a seizure. Okay. By seeing his sister, okay, giving more importance, then he started doing this. Whenever he wants something or when he is demanding something, he used to make this. So this is not a case of seizure. So no need for antiepileptic drugs to be given here. Just see this video. Patient is on supine. The heart rate is 115, respiratory rate is 38 with a blood pressure of 115 by 80. So now the patient is asked to sit. See, now the blood pressure after sitting, it became 60 by 40. The heart rate increases to 138. So when the patient is asked to stand, the patient is having some abnormal movement and fall. So is it a seizure? No, it is not seizure. What is this? It is orthostatic hypotension causing drop in the sensorium. So not all LOCs are seizure, not all falls are seizure, not all stereotypic phenomena are seizure, not that all seizures are seizures, not all jerks are epilepsy, or not all paroxysmal events are seizure. Please remember. Okay. So once this is over, then we need to know whether it is a provoked or it is an unprovoked seizure. So symptomatic seizures or any provoked seizure, there will be some kind of acute medical or neurological illness. Example, like a febrile seizures in a children, seizures in a CKD patient, or hyperglycemia, or drug withdrawal, or alcohol.
No.
Patient is having any kind of brain infections like meningitis or encephalitis, then we call it as acute symptomatic seizures. Clear? So this is a 55-year-old male, recurrent attacks of some impaired consciousness lasting for 1 to 2 minutes, 5 to 10 attacks per day since 3 days, and having some kind of automation is there. You just watch this video. Only list snatching is there. You can see. When we check the blood glucose, sugar is showing 425. What is this? So it is due to hyperglycemia. You just see this is a patient had consumed some poison. This is a continuous GTCS. This is due to endosulfan. So acute symptomatic seizures, antiepileptics are used to suppress the seizures acutely. So it is just a momentary we are giving. They don't need for a prolonged time. So the drug should fit. So partial seizure, the drug of choice is phenobarbital, phenytoin, carbamazepine, oxcarbazepine, sodium valproate, and limon. So in our practice, we always prefer carbamazepine or oxcarbazepine out of these drugs. Whereas in a generalized seizures, sodium valproate or tropamide or levetiracetam can be preferred. So now we are all using only levetiracetam. Single most criteria, okay, just to start AED, how you are going to start. So the question should be, is it a seizure? Yes, it is a seizure. Is it an unprovoked seizure? Yes, it is an unprovoked seizure. Is it recurrent unprovoked seizure? Yes, it is recurrent unprovoked seizure. Then we have to plan for a long-term anti-epileptic therapy. Otherwise, no long-term anti-epileptic therapy. So how and what to start? Always start it as a single monotherapy. So I have seen a lot of prescriptions having 3 anti-epileptic drug for a simple seizure. No need. Okay. So we have to evaluate based on the patient's condition. What is the efficacy? What are the tolerability? The cost, that is very, very important for a long term in a chronic patients. The cost of the drug and how much it comes for the patients for the monthly expense. So we have to calculate and look for any comorbid condition, and then we can start. In case of pregnancy, okay, patients. So no case of epilepsy, stopped the drug, having an active seizures. We have to treat with the anti-epileptic drugs. So along with anti-epileptic drug, we can add folic acid and vitamin K. Okay. This is a 24-year-old preemie, unbooked, having a seizure. Hypertension is there, edema, proteinuria, diagnosed as case of eclampsia. Magnesium sulfate is given. Patient is having an hypercoagulable state. So if you are not properly treating, the child will come with the meningomyelocele. Okay. You can see the congenital deformity. The patient will go for a meningomyelocele. Very commonly we see now alcohol withdrawal, especially during the Ayyappan season, when they are having a fasting, they will go for a sudden absence of alcohol, they will go for a seizures. Drug abuse we see. The important complications in drug abuse, we don't have any IV access. So most of the time, these IV access will be all thrombosed. So repeated. Even few drug abusers, they are taking a pocket shot and they come with a pneumothorax. So ideally, we can go for a rectal, buccal, or now latest we are having a nasal midazolam that can control the seizures. The trauma, immediately it can cause, and within 7 days it can cause. And certain is where the gliosis will occur in the contusion area and maybe a foci for a generalized epilepsy. Okay. So mostly in a post-traumatic, if you are properly handling, not more than 10 days. Okay. The frontal lesion and the temporal lesions are very worst contusion area. Especially the frontal lesion, they will have a continuous seizures. So the patient with the previous seizures, known case of epilepsy on treatment, suddenly stop. We call it as a bus seizure. Okay, the drug incompliance can be there, the half-life, and that in that case, no need to directly start oral regimen. You give IV regimen, make the serum level optimal, then you can switch over to the oral regimen. So there are certain area where the patient will come as a first seizure. Okay, the age will be around 40 or 50. They are not having any seizure at all in their lifetime, and suddenly they will come. So there we need to know, look for the etiology, precipitating factor. Definitely we have to look for a CT brain, EEG, and then you start AED. Single attack of unprovoked seizure. Okay, what is the risk we see? There is a 15% of the risk at 1 year, and 34% at the 5 years, and around 80 years at the 5 years. there are with various different factors. Okay, the risk factors for recurrent seizures. Recurrence is occurring is pre-existing neurological insult. It may be an hypoxic injury, or it may be a trauma, or it may be a gliosis, or it may be cysticercosis, else anything. Okay, that can cause an unprovoked seizure. So the decision to treat after a single unprovoked seizure is always depends on the risk factor and patient's wish. And sometimes patients say, sir, I'm not interested in treating this. So they will not be compliant with the drug. So no need to treat the patients. So we have to look for the risk factor, precipitating factor, provocating factor. Then we can try to minimize that. Okay. So the consequences of the job and the patient's thing. So this is one paper, Tamil newspaper, okay, where the patient driver had a seizure, okay, then had an accident, okay, because of the conductor, all the passengers have been saved. This is another one, saloon, when there was a barber was shaving, okay, and suddenly he had a seizure. So this person had a nick over the carotid, and the person who is there for shave died in the saloon seat itself. So this kind of patients are to be treated properly. Okay, this is another coffee master who had a seizure and had a fall over the fire and had a very ugly burns injury. This patient had a bite, tongue bite. You can see when totally tongue has been cut, we sutured. So many times, okay, even certain professor used to say to know whether it is a seizure or not, if there is any tongue bite. There are few patients who are not having exactly a seizure but have some kind of tongue injury that should not be considered as a seizure. Okay. So now you are moving into a status epilepticus. That is very, very important. In any tonic-clonic seizure where the breathing is impaired and status is a medical emergency. Okay, this is many time misdiagnosis and very, very important to treat. Okay, the prolonged seizures. Okay, in endosulfan poison, or the patient is having some hypoxic injury, uremic encephalopathy, or hepatic encephalopathy. The temporal systemic changes will be there, and life-threatening systemic changes can occur. And as the duration of the seizures is increased, the patient can die. So, in case of resistant seizure, you are treated as per protocol for the status epilepticus. There are certain time we used to face the resistant seizures where the midazolam infusion of 1 to 10 microgram can be given as a bolus, and continuous infusion can be given at the dose of 0.15 milligram per kg. Still the patient is throwing convulsion and you are not able to there, then you can think of phenobarbital. This can be given as an infusion. And very important thing, when you are giving a patient on phenobarbital infusion, this patient can mimic like a brain death. Please understand the pupillary reflex will not be there when the patient is in a barbiturate coma. So that has to be clearly explained to the treating doctors or the nurses so that they will not get panic. So it is very, very important to know what is the type of seizures, and we should not fail in handling any other thing. See, this is a video where he jumped and unfortunately he died of others. So don't forget, as an emergency physician, my mantra is always taking care of airway breathing circulation. Thank you. Any doubts?
It was a nice presentation, sir. But I wanted to ask sir one question regarding pregnancy. Vitamin K in pregnancy, while patient has seizures,
Yes, sir.
is it advisable in all the trimesters, sir?
Sir, actually, in all the trimester we can give. There are papers saying that by giving vitamin K1 and folic acid, okay, so this helps to prevent the congenital neurological malformation in the fetus. So nothing harm in giving a vitamin K1. But this is not we are going to give for a prolonged period. Just a temporary. Okay. just for 5 days or 10 days we can give, and then we can stop it. Any other doubts?
Sir, can we give the same midazolam ampule via rectal route to a young kid like who is in active seizure instead of giving IV?
Ma'am, rectal can be given. Same thing can be given. There is nothing special preparation is needed.
Okay. So the dose also remains the same?
Dose little higher we can give, ma'am. Normal point instead of 0.5, we can give 0.20 or 0.25.
Okay, sir. And in febrile seizures also we can give, no? Many times we get a lot of children with febrile seizures, so we can
Yes, ma'am.
give that, no? Yeah.
Yeah.
Thank you, sir.
Instead of rectal, now there is a nasal spray is there. It is very easy. Just you spray and then it settles very fast.
Okay, sir. Thank you, sir.
Hello, sir. Good evening, sir.
Good evening.
Sir, if a patient is presenting after the seizure episode, that is, he was having seizures in his house, and now he is presenting in post-ictal state. Still, do we need to give benzodiazepines, or is just the fentanyl enough?
Benzodiazepine is a first drug of choice. You assess the patient and there is no compromise to airway breathing circulation. Then we can give a benzodiazepine as a first line of drug. Then you can convert them, assess, do other evaluation, and then if needed, you can start him on antiepileptic drugs.
Okay, sir. If even though if he is in post-ictal state, still we need to give drug,
I
because
couldn't
most
get
of the
your
patients will
question.
have seizures in their house, and while coming to emergency department, they will be having their seizures controlled, but they will be in post-ictal state.
If
In such a case,
the patient is really in a post-ictal state, there is nothing harm in giving an midazolam. You can wait
okay,
and watch. Or if the patient's having some kind of video, see, most of these videos are taken by my patients. Actually, I want to show a lot of videos, but it is not playing. We have a different cases. Almost 75 videos are having. I'm having.
okay, sir. Okay.
Sir, I have one question. Suppose I had one patient of status epilepticus and there was no past history of seizure, and he was a young boy of 20 years. And he kept seizuring for like almost 15 minutes till took him to AIMS. So on the way, I had given already twice like 10 milligram IV diazepam. So I was thinking in such cases, can we give like phenytoin IV, like because there was no history. So how justified are we to give phenytoin IV in such patients?
Phenytoin, it is very, very important to give phenytoin in a generalized seizure. But in toxic seizure, you should not give one.
Okay, sir.
Any other doubts?
Thank you, sir. Thank you.
Thank you. Good night.